I would like to introduce our speaker today. I'm very excited to have my colleague here, Dr. Kim Werner. She possesses an interdisciplinary expertise in behavioral neuroscience, psychology, and addiction epidemiology. She earned her doctoral degree in behavioral neuroscience psychology from the University of Missouri St. Louis and completed a postdoctoral fellowship in transdisciplinary addiction research at Washington University in St. Louis. Currently, she serves as an associate professor and associate dean of research at the College of Nursing. That's at UMSL as well, at the University of Missouri St. Louis. Dr. Werner's research explores biopsychosocial alterations associated with intimate partner violence, post-traumatic stress disorder, and trauma-related symptoms. Beyond research, Dr. Werner leads initiatives to combat gender-based violence as the principal investigator of Tritons United Against Gender-Based Violence grant from the Department of Justice, Office of Violence Against Women. Dr. Werner is also the chair of the Institutional Review Board at UMSL University, and she was very recently, as in last week, awarded the 2024 Trailblazer Award from UMSL for her work in diversity, equity, and inclusion, given her extensive advocacy for others, promoting ethical research, and advancing social justice for all. So we're very excited to have her here to talk to us about some of her research, and she's going to go ahead and pull up her slides. Welcome, Kim, and she said she's very laid back with the presentation. If you have questions or clarifications while she is presenting, she's going to pause at the end of each slide, and feel free to, you can put your comment in the chat if you prefer, or you can unmute and ask her directly.
Yep. Thanks so much, Kate. Yes, so I am very laid back, and I am a huge proponent of I do not know everything, and I have a room of experts who know a lot more than I. So if there are things that you want to discuss further or have questions about or find interesting, I'm happy to have that dialogue. So thank you so much for coming today. I'm very grateful to be invited. As Kate said, I'm Kim Werner, and on behalf of my co-authors and I, because in my opinion, all research is done in great teams, I'll be presenting our work entitled The Contribution of Traumatic Stress and Brain Injury to Predicting Global Functioning in Women Survivors of Intimate Partner Violence. I have no disclosures. So as I said, I am a huge fan of teamwork. This is the colleagues that I would like to acknowledge and the work that they have done and my partnerships. But I also think it's important to thank the women survivors of domestic violence who share their stories with us and allow us to do this work to support the community, because they've gone through a good amount, and we are very fortunate to be able to work with those individuals. So I'm fully aware that most people on this call are very familiar with intimate partner violence and traumatic brain injury, but I'm going to speed through these first few slides just in case there are people who are new or visiting and just checking things out. So as we know, IPV includes physical, psychological, and sexual violence by past and current intimate partners. A third of women in the United States experience physical IPV during their lifetime. And compared to men, research shows women experience more severe assaults from partners and sustain more physical and psychological injuries from those assaults. Nearly half of women who experience IPV develop post-traumatic stress disorder and comorbid disorders prior to childhood. Physical and sexual abuse are also prevalent among IPV survivors. And there's a substantial cumulative trauma burden in this population, which contributes to PTSD and depressive symptoms developing. And we know through research that left untreated PTSD and depression can persist for years after abuse, can cause massive issues in global functioning and wellness, and it increases the risk for re-victimization later in life. So the lingering effects of physical injuries and the overall impact of IPV on physical health can further complicate the clinical presentation in this population. Injuries from IPV are inherently different from non-IPV injuries in that they're often severe and repetitive, enacted in a chronically invalidating environment from which there's little opportunity for escape, and are often unreported, underdiagnosed, and untreated. That said, research on TBIs from IPV are in its infancy, and thanks to groups like this, we can have these conversations, and we're kind of catching up, hopefully, to other types of TBI. But it's estimated that TBI and head injury in IPV survivors exceeds those that occur secondary to falls, motor vehicle accidents, combat, and sports injuries combined. In addition to TBIs, research has reported that 2/3 or 75% of IPV survivors experience strangulation, which can cause anoxic brain injury, further complicating the clinical picture that we see. So, because of all of these things, we know experiences of intimate partner violence have been associated with poor quality of life and other measures of global functioning. The impact of PTSD on physical and mental health is well documented in IPV populations, but the potential importance of TBI and head injury is just emerging within any population, much less the IPV population. So previous research in the general population with TBI compared to orthopedic controls or friendly controls show mixed results, which could potentially be due to assessment type. So we will be using 3 different assessments in this study. We also have findings from veteran cohorts that demonstrated the importance of psychopathology in predicting global functioning, but mixed results pertaining to the contribution of traumatic brain injury. As you can see on this slide, and I apologize for the small type, PTSD and TBI have really overlapping symptomatology that complicate the overall picture as well. So as I mentioned, not only is PTSD reported in high levels in this population, but women with TBI are even more likely to be diagnosed with PTSD. So many researchers, and I'm sure clinicians, believe this is in part due to the overlapping symptomatology of PTSD and TBI, including the irritability, insomnia, memory difficulties, depression, anxiety, and impulsivity. Although these symptoms often have differential etiology in the PTSD and the TBI, the way that symptoms are presented and the behavioral effects of those type of underlying issues can really be difficult to distinguish in a clinical, much less a research setting. So the overall objective of this comprehensive study was to describe the clinical, physical, and neurological health of women survivors of intimate partner violence, paying particular attention to co-occurring TBI and PTSD symptomatology. My specific study that we'll be looking at today is examining the impact of exposures of a traumatic event, severity of PTSD, and repetitive head injuries, including TBI, on quality of life, global functioning, and life satisfaction in this sample survivors of IPV. The more comprehensive assessment that I kind of described in this first piece was reported in a parent paper in 2001, and I can refer back to that for any overall descriptive characteristics or findings for that study as well, if there's any discussion pertaining to that. All right. Again, sorry for the small type, but I wanted to make sure you knew where we got our people from, because I think this is a really important piece. One of the limitations that I'll discuss later, not to be a spoiler or anything, is, we screened individuals who came in, and those who were positive for probable PTSD were invited to potentially participate in the study. I do think our study findings might be a little bit different if instead of having a primary focus on post-traumatic stress disorder symptoms, we had a primary focus on traumatic brain injury exposure or head injury exposure. So when we go to the results section, I definitely want to discuss that and take that into account. But we recruited individuals through domestic violence shelters, the VA, social service agencies, social media, and in the general population. And because we included a neuroimaging component as well as bioassays, We chose women between the ages of 18 and 45 to make sure that there was no normal cognitive decline or any normal aging issues with the neuroimaging component. All had a history of intimate partner violence and screened positive for probable PTSD. And we excluded folks who had a history of neurological illnesses, seizure disorders, schizophrenia, psychosis, and current active homicidal or suicidal ideation. 78 women were assessed for eligibility and 51 were enrolled in the study. And of the 51, 41 were found to meet for current full PTSD diagnosis. So that's with the DSM-5 diagnosis structure. 7 were subthreshold and 3 were PTSD negative. Of those with PTSD or subthreshold PTSD, there was significant history of traumatic brain injury, head injury, and repetitive blows to the head. That includes both within an intimate partner violence situation as well as outside of IPV. Oh, thank you, Kate, for sharing that. I appreciate it. I also have it open, so if we need to refer to it, I can. The parent paper Kate just shared in the chat. Okay, so the assessment we used in the overall study, as I noted, is extremely comprehensive. We've had clinical assessments, the CAPS, the SCID, a battle, which is for head injury. We had self-report measures, we did neuroimaging, we did neuropsychological cognitive assessments, and we also had blood biomarker testing. And the full methodology is in the link that Kate just shared in the chat, if you would like to look at that more in depth. But for this study in particular, the main outcomes included these 3 outcomes. So quality of life, global functioning, and satisfaction with life. So the quality of life inventory is a self-report measure developed to assess quality of life across 16 different domains. So for example, love, work, play, finances, relationships. And each of them examines how important these areas of life are to the individual, as well as their current satisfaction within that domain. For global functioning, we use the World Health Organization Disability Assessment, the WHODAS, which is a self-report questionnaire that asks about difficulties experienced in 6 domains of health: understanding and communicating, getting around, self-care, getting along with people, life activities, both in work and school, as well as participation in society. And then finally, the satisfaction with life scale is a global measure designed to measure global cognitive judgments of one's life satisfaction. So for example, I'm satisfied with my life. The conditions of my life are excellent. If I could live my life over, I would change almost nothing. So really global scale questions. So these are our main outcomes, and these are our predictors. So predictor variables included interpersonal trauma exposure during childhood and adulthood, as well as PTSD severity, traumatic brain injury, and head injury exposure, as well as repetitive blows to the head. So the trauma interview captured participants' trauma exposure history across the lifespan, including intimate relationships, but also outside of intimate relationships. Within the intimate relationships, there was specific focus on violence within those relationships, injuries sustained during the assaults by intimate partners, and the utilization of resources following the intimate partner violence exposure. The CAPS, the clinically administered PTSD scale for DSM-5, was administered by a trained assessor, and the battle was actually developed for this project based off of the battle that's been used in the TRACS protocol for a long period of time. The battle IPV was designed and implemented specifically for these female trauma survivors to target diagnostic issues that were specific to this population. So while it maintained kind of that lifespan approach of traumatic brain injury and head injury exposure, it included questions related to IPV as well as non-IPV related TBI and head injury exposure. So I think to note about TBI, head injury, and repetitive blow, I think it's important, and I hope folks would agree that considering the contribution of these different types of head injury is really important, particularly with this population. Research has shown that there's, deleterious and impactful, difficulties with TBI, of course, but also head injury more generally and repetitive blows to the head, of course. That's not even to mention chronic traumatic encephalopathy within, NFL and other things. But I think that's really important to consider each of these potential types of head injury when looking at cognitive functioning, mental health, and global functioning for this participant group. Oh, Kate, you're just dropping all the good stuff in the chat. Thank you. Okay, so just participant characteristics kind of slide. I can provide much more detail, and that 2021 paper definitely does too, but predominantly our participants were white and just shy of middle age. That hurts my soul. I just turned 40 this past year, so it hurts my soul to say 32.6 is just shy of middle age, but we know that to be true. And low income. Overall, they reported chronic childhood and adult trauma histories, and participants reported spending more than half of their adult life on average in an IPV relationship. That's not just one singular relationship, but within their life, having multiple IPV relationships, that many of them were abusive. The majority met for current PTSD and or high levels of comorbid disorders, including major depression, substance use disorder, and panic disorder. The vast majority reported a lifetime of severe head injury, and over half reported a traumatic brain injury on the battle. And of interest, I think it's also really important to note that 31.4% reported strangulation by a partner, including an anoxic event due to strangulation, which was reported in, let me pull that up real quick. Choking with a loss of consciousness was reported in 4 individuals, so 7.8% of the population.
Kim, this is Kate. Can I ask a clarifying question?
Yes, please.
You're just mentioning the proportions of the sample here. I know we have just over 50% had a traumatic brain injury based on the battle.
Mm-hmm.
Do you recall the proportion with the brain injury from an intimate partner?
Yes.
Is it 50% here, or
It
is
was
it more like 30?
35.3. So the prevalence of TBI secondary to intimate partner violence was 35.3. So that was 18 individuals. And the prevalence of TBI lifetime, so that would be within IPV or outside of an IPV exposure, was 27, so 52.9. So that's what that number reflects here.
Got it. Thank you.
Thanks for that clarification. And I think, just to hit that one home too, many people experienced multiple head injuries, some of them experiencing multiple traumatic brain injuries in their lifetime. So, there were individuals who endorsed experiencing both a non-IPV related TBI as well as an IPV related TBI. All right. So the results for our first outcome, quality of life, I ran a multilinear regression analysis, which revealed that the development of PTSD subsequent to trauma exposure contributed to poor quality of life. So trauma exposure itself, TBI, head injury, and repetitive blows to the head did not significantly predict current quality of life. And these findings were actually consistent in both the multilinear model, but also in the a priori univariate models. So PTSD was the only significant predictor, whether we ran each of these predictors independently of one another or put them all into one model. So it's not like there's this covariance thing happening where PTSD symptoms are trumping head injury or TBI. PTSD was the only one that actually reached the level of significance when predicting quality of life. And we see a similar story for when we look at global functioning. Higher educational attainment was associated with less functional disability, which we would potentially expect, right? It means higher education is associated with better global functioning, while PTSD severity, again, was associated with poor outcomes and increased disability and functioning. Again, none of the 3 head injury predictors were significantly associated with global functioning. I would like to do some additional analyses to look at the subdomains. There has been some data to suggest that the questions that are asked related to TBI or related to functioning matter when you're asking about the relationships between these factors. So that is something that I'm planning on moving forward with prior to publication as well. And then when we look at the satisfaction with life, we see almost identical story. Education was positively associated with increased satisfaction with life, and PTSD severity was negatively associated. Head injury, again, did not have any predictive effect on the satisfaction with life outcome. So this study is one of the first to examine the impact of PTSD and TBI/head injury on functioning outcomes in IPV samples. And although the findings were not necessarily showing a relationship with the head injury outcomes, they did confirm the importance of considering PTSD specifically when it comes to these functional outcomes in IPV. And I will note this is a small sample, and looking at these questions in a larger sample as well as in more permutations, looking at different subdomains and things of that nature would be relevant and highly important. As survivors might present in an emergent setting, so an emergency room with head injury or trauma, PTSD screenings would be great to see if there's a way that we can identify that early. In acute care settings and women's health settings, doing IPV and PTSD screenings could be a really great essential primary prevention strategy. But I think generally speaking, considering PTSD as well as trying to identify IPV early on must be a priority for women's health over any type of setting. And this study, like I said, I'm a huge future directions, look at the limitations, poke the holes kind of person. This study has lots of limitations, including that small sample size. The chronic repetitive nature of trauma exposure in this population, and that coupled with the multiple head injuries, the multiple TBIs, the repetitive blows to the head, the strangulation, can really limit their ability to disentangle the temporal impact of trauma and head injury on these outcomes. The study was conducted in a PTSD population with the primary focus on TBI and head injury. So it would be interesting to see how these results might change if the study was in a TBI head injury population with a secondary focus on PTSD, because there's just more variance potentially in the PTSD population, and then the head injury, considering those factors and flipping those to see how these different things permeate would be really interesting. Future research in larger, diverse populations is definitely warranted to elucidate the independent and compounding effects of trauma, as well as psychopathology and head injury over time in this chronically traumatized population. And, does early screening and intervention for PTSD improve these outcomes for patients with TBI and head injury? What are the important factors related to TBI that we need to be paying attention to that are impacting the well-being and functioning? Maybe there's specific sub-factors we need to consider, or specific behavioral symptoms that we're seeing that have more of a deleterious effect on these outcomes. All right, thank you. I'm not sure if I went too fast or too slow, but thank you for your time. And I appreciate all of the work that you do and look forward to collaborating in the future, hopefully.
Kim, thank you so much for that presentation. It was great. I'm sure people have comments or questions, so I'd like to to open the floor for folks to unmute.
I answered all the questions. Just give me the Nobel Prize now, or, you know.
I'd like to ask a question if I could.
Please, Mary, go ahead.
Yes, hi. Thank you for that presentation. I'm not a neuroscientist. I want to tell you that. I work for a company called Wave Neuro, and I also run a nonprofit called Just One Wave. And one of the technologies we're looking at is actually we're bringing true phase 2 clinical trials is for PTSD right now. I'd be interested, I know it's not a part of this study, but in your experience, what kind of treatment do these women seek when they are diagnosed and they're looking for some kind of treatment for PTSD? What kind of treatment are they getting in your experience?
Yeah. Well, Kate may be a better person with treatment stuff, but I will say, in addition to this parent study, we actually had a sub-study that looked at implementing masked cognitive processing therapy compared to normally delivered cognitive processing therapy for 12 of the folks who enrolled in the parent study. So out of the 51 individuals who we enrolled in the parent study, we invited 12 of them and then randomly assigned them to masked CPT, which was delivered in a 5-day period of time. So 12 sessions in 5 days versus normally delivered cognitive processing therapy. And we ended up seeing that endpoints were very similar, where those, who received mass CPT versus those who received the traditionally delivered CPT over 6 to 12 weeks actually ended up being very comparable on their PTSD gains, or I should say reductions in their PTSD symptomatology. So cognitive processing therapy is definitely the treatment that I lean towards, just because I'm like I think, what did I refer to at one time, Kate? I'm like the research granddaughter of Patty Resick, because Tara Galovski was one of my mentors, and she's the parent of the mother of CPT. So I am partial to CPT. I would say prolonged exposure as well. Kate, I know that you have done a number of different types of treatments in this population, so you may have some more additional recommendations.
Right. Well, CPT is a great one. Cognitive processing therapy is what that stands for. And there's, some really great evidence-based psychotherapies for PTSD that were like originally developed for survivors of interpersonal assault, including sexual and physical violence. And so prolonged exposure is another one of our frontline therapies. They work through kind of different mechanisms. There are other great options with growing data as well. Have you heard of EMDR, eye movement desensitization and reprocessing? And then a growing evidence base for, somebody help me out here, I want to say PCT, but it's not coming to my head. What that's presence-centered therapy. I just needed a second, which was traditionally used as a very supportive control condition, but has been found to have very useful outcomes for people with PTSD. And so that's another promising area. And an interesting thing we found in our research is that among interpersonal violence survivors, when their PTSD and depression is reduced effectively during cognitive behavioral therapy, they're less likely to experience intimate partner violence in a future relationship. So another pro to effective PTSD treatments, they're hard to access in the community.
And thank you for the information too. As you can imagine, our phase 1 trials and the early work was predominantly done with veterans and sports people. And so I've only recently, since sitting on this task force, started to hear about this. It's astounding number of women that are affected with through IPV. And now that we're in the phase 2 trials and open up to civilians, we do have a lot more women coming into the trials, which is good to see them, actively participating. So we'll look forward to hopefully having some benefit there. So thank you very much, Kim, for your presentation.
Thank you for all the work that you all are doing. It's great. I do see we have a comment in the chat. Study indicates that PTSD symptoms increase when satisfaction with life decreases. How did you account for the overlapping symptoms of PTSD and TBI? How were you able to determine that PTSD symptoms were not symptoms of TBI? So I don't think any methodology is foolproof, but I will say that the assessments that we used for both TBI and PTSD were not just self-report. They were clinically administered by trained assessors who were, and we had inter-rater reliability. We did lots of the things to make sure, weekly meetings with, very strong clinicians, Regina McGlinchey and Kate Fortier and Kate Iverson and Tara Galovski, to make sure what we were doing was correct. So I would say that the symptoms that were identified for PTSD via the CAPS and the symptoms that were identified for traumatic brain injury in the battle, we can be pretty confident that those were being parsed the proper way. So when you're asking about the different symptomatology in those clinical interviews, you are specifically looking for things related to cognitive distortions or difficulties that would be related to the trauma itself for the CAPS. And then for the battle, you'd be looking for changes that would be related specifically to a traumatic brain injury for the battle. So there's, kind of additional kind of probing questions that you ask within those clinically administered scales that allow you to parse and determine if those symptoms fall within the PTSD or the TBI. Thank you.
Kim, where else do you see your research going? I know you talked about some future directions for this study.
Yeah, I mean, I have over the past 3 or 4 years gotten really interested in actually getting, some boots on the ground and doing the work, not just being my nerd behind my data analysis and pulling people in to probe them with things and questions, but hopefully trying to integrate some of these screeners and some of these primary prevention and secondary prevention tools within care settings. So now that I'm housed within the College of Nursing, I have a ton of students that are both doctoral from a PhD perspective, but also Doctor of Nurse Practice students who are doing quality improvement and actually implementing practice change within different units. So making sure that I'm helping them translate some of this evidence base that we're seeing, where we know that these different types of prevention strategies are needed, these different types of outcomes are occurring, and figuring out best practice to actually get them implemented into practice where we can, immediately respond to, assess, and hopefully treat individuals who've experienced these types of concerns, both PTSD as well as head injury. So I'm hopeful we can do more of that and I will always be a data nerd and want to look at things from a more epidemiologic standpoint. So if there's ways that we can start to capture the experience in larger samples, I think that that's ideal. So if there's ways that we can integrate this into national surveys, if there's ways that we can somehow get a larger population to really see what's happening, and if time and different policies and public health initiatives are changing the experiences that people are having, I think that would be amazing as well. Your interest in connection to nursing, working with the Children First nurses who could be practical and really cool. Generally according to public health departments. Great. I'm going to write that down, because we actually have a really strong connection with the St. Louis Public Health Department, St. Louis County, and St. Louis City. So that would be excellent. Children First. No, now that you say that, I'm one of those weirdos that keeps a notebook by the side of my bed when I have dreams about things. Now you say children first. I actually wonder if we could look at the experiences of children who have survived domestic violence and look at traumatic brain injury and head injury within those populations as well. I'm not sure that that's been something that's been tapped. Thank you, Emily. That's great. So if anyone interested in looking our current clinical trials for PTSD. Oh, great. Thanks, Mary. Oh, that's a cool graphic on your.
Last chance to ask him your questions or raise a point for discussion amongst the group. I did just get permission from Catherine and Eve, for all of you fans, to share a couple of photos from their trip, but I'm having trouble figuring out how to put them
I
in
can
the
stop
chat.
sharing. There you go.
But it looks like they're having a great time. I'm struggling with getting it in here. Can't copy and paste.
I have a question while we're waiting for those sought after photos. I wondered how you felt like the administration of the interview went. Like, do you have some feedback from the end user perspective and how those in the process of delivering those instruments?
So we actually started with 2 assessors. One of them was public health trained masters in public health, and one of them was a licensed clinical social worker. And it was interesting because I thought when we started with the social worker and training them and making sure they were ready to go before even having participants, that they were going to be the stronger assessor. When in reality, stronger assessor ended up being the masters in public health individual. The social worker was more interested in not necessarily sticking to the probing questions, but almost trying to help them in a social worky kind of way, right? Like more holistic, comprehensive. How can I, help you? Almost like a therapy session, frankly. Whereas the public health expert really stuck to the script and stayed with the prompts. The feedback that we received from our rater, we had an external validity raters, was very positive in that it was getting enough information as needed, but not, causing too much harm to the individual themselves, and also sticking to the prompts. So that was kind of the feedback that we received from that rater. I will say anecdotally, we did not receive any, information about kind of a process evaluation from the individuals who were the participants, because their experience was so long. So we had each of them for 2 days. The first day was an 8-hour day. And we started with some self-report measures and some rapport building before moving into the structured interviews. And then the day 2 was at our partner, Washington University in St. Louis, where we did the MRI and the blood draw. So by that time, everyone was old chums, right? There was a really strong rapport had been built with the participants. But on day 1, we tried to spend some time with the participants to build that rapport so they felt safe and comfortable in being able to provide the clinical information that we were trying to gather. We tried to make the room very cocoon-like. We had snacks and drinks for everyone so that, we brought lunch for everybody. We provided transportation, so that wasn't anything that they needed to worry about. So we tried to provide kind of a very supportive environment so they felt like they could disclose and be candid with us. I'm not sure if that answers your question, but.
No, that's helpful. It's often information missing from the, papers, like
Yeah.
these very important details.
Yeah, I mean, our number one priority and my number one priority always is making sure that participants are comfortable and risk is mitigated, and not just from a practical, sterile sense, but from a person moral sense. So when we were thinking about implementation and the best way to make sure that participants didn't feel like lab rats, but actually felt like humans that were being supported and that their responses were helping to not only move science forward, but to support other survivors, we really kept that at the forefront and tried to make sure that the experience they had was a very positive one.
Thank you.
Yeah, and Angela, I'll just add, that it's a research interview, so it's lengthy and detailed, and that's why it's so thorough, and we feel confident about, differentiating brain injury from a head injury that didn't meet the threshold, but it's also very long and not practical necessarily in the context of clinical care. So that would be a downside, but Dr. Fortier and her colleagues are working on a briefer version of the assessment. This is what's practical in research, and then there's, which is important to be thorough, and then having kind of more thorough assessments in clinical care that are feasible are important too.
And great photos. So
Oh,
thank you.
yeah, like they're having so much fun.
Mhm.
So thanks for sharing the other talks. Perfect. Well, thank you, Kim, for sharing your work with us. This was really interesting. And
It's our work, Kate. It's our work.
thanks for sharing our work with the group. But we haven't connected in a little bit, so it's fun to reconnect and move this forward. You did a great job getting lots of compliments in the chat. So we
Yes, thank
appreciate
you.
it. We appreciate everyone for tuning in and for your good questions and discussion. And special shout out to Casey from the Ohio Domestic Violence Network for helping out today with the tech. I in particular really appreciate it, Casey. Thank you.
Yes, thanks, Casey.
All right. We'll see you in the same place, same time in a month.
Bye, thank you.
Thank